I take pleasure to introduce to you our renowned speaker for the day. So I take pleasure to introduce Dr. Aritra Pradhan. Dr. Aritra Pradhan has completed his MBBS as well as MS in obstetric and gynecology, and he is operating as a IVF specialist at Srishti Hospitals and Research Center. Talking about skills and trainings, Dr. Aritra Pradhan has gathered his knowledge from every zone of the country. He has been skilled and trained in ART, Embryology Academy for Research and Training from Mumbai, which is West Zone. The USG training has been completed from Malhotra Test Tube Baby Center from Agra, which is North Zone. Laparoscopy training, Dr. Aritra has completed from Paul's Hospital, Cochin, which is in East Zone. So he completed his high-risk pregnancy training from Ian Donald School, Moscow. Talking about his achievement, he has performed more than 10,000 cycles over the last 12 years and has successfully delivered 3,000 IVF baby leadership in healthcare, innovative healthcare IVF. He was a gold medalist post-graduation days in obstetric and for post-graduation exam, CL Zaveri Award for Best Oral Paper Presentation at National Conference on Evidence-Based Medicine in Gynecology at Ahmedabad 2008. Best Paper Presentation Award in UFOXY at Ahmedabad 2007. And Best Paper Presentation Award in UFOXY Kolhapur 2008. So we have a true academician as well as a thorough practitioner with us. So Dr. Aritra Pradhan.
Good afternoon, everybody, and warm greetings from the Northeast and the tea capital of India. So unlocking IVF, redefining the new normal. As we are going through this second wave of pandemic, and we are all hit. We are all hit very hard. And we all know that. So I'll try to go to the IVF where we can start and how we can start, what we can do and how we can do, what protocols we can follow, how to give support and everything. So, IVF, unlocking the key to the infertility. So we all know that 1 in 8 couples experience difficulty in conceiving. And we all know the process of IVF, just for everybody's recollection, that we do ovarian stimulation using gonadotropin hormones, then egg collection, then fertilization of the egg, either doing by IVF or ICSI, then culture in the lab, and then transfer. So all this process, during all this process, we have to be very careful, and then how we can start all this. So increasing demand of IVF, and as we know, even in this pandemic also, the couple who are suffering from this, they're coming to us, they're asking when we can do and how we can do. So there is increasing demand for IVF because of increase of maternal age, the genetic relatedness, gestational carriers, lifestyle, genetic abnormalities. So the increasing demand of IVF treatment drives research and development of technologies to optimize IVF regime and success. So which are the most popular investigations and evaluation prior to IVF? So before doing this, when you are starting your evaluation, now the protocol is that we have to do a rapid test or an RT-PCR before even starting the investigations for the couple. So coming to the common blood test, you all know basal serum FSH level, serum estradiol level, clomiphene citrate challenge test, basal serum inhibin B level, AMH, GnRH stimulation test, or exogenous FSH ovarian reserve test. So other investigations prior to IVF. So because patient is coming in contact with you now, so there should be, I'll come to that, there will be a triage, there will be a questionnaire. We are doing the patient's test. Before that, we are doing either an RT-PCR or a rapid test and starting this. So we are going for ultrasonography, where we can do for ovarian volume, total antral follicle counts, ovarian stromal blood flow, and the sonographic assessment of the ovarian reserve, and is advantageous in selecting the poor responders and choosing appropriate stimulation protocols at the beginning of the cycle. So evaluation of the uterus, you all know, either by saline sonohistography or hysteroscopy, or a trial or mock transfer, either prior to IUI or IVF. And then the semen analysis, of course, for the male partner. So what are the guidelines and recommendation on good practices to be followed during the current pandemic? So I was talking about this. Even ASRM and ISHRE And from ICMR and the ISAR and ACE guidelines, all are the same. They have told discontinuation of the reproductive care except for most urgent cases, because the second wave, it's in the peak. But as it is coming, the lesser cases are coming, and even the selecting areas like where there is a containment zone or there are more cases, we can suspend the new treatment cycle. We can counsel the patients for their suspension or postponement, or you can cancel the embryo transfer, whether it is fresh or frozen. Provision of care for the patients who are currently in cycle, who require urgent stimulation or cryopreservation, and suspension of all elective surgeries and non-urgent diagnostic procedures. Even ISRE has told the same, that avoid complications from ART and pregnancy, avoid potential complications, mitigate the risk of vertical transmission, support the necessary reallocation of healthcare resources, and recommendations for social distancing, all. So what we can do a fertility preservation or oocyte or embryo vitrification for the patients who need undergo immediate gonadotoxic oncologic treatment. We can do oocyte, embryo, or ovarian tissue cryopreservation before surgical procedure for infertility treatment like severe symptomatic endometriosis, and freeze all for patients having started ART at the present time. So good practices, how good practices? So there are 6 pillars of good medical practices proposed to restart. So discussion and agreement and consent to start of the treatment with the couple and with the hospital. There are forms available. There is triage forms available from ACE and ISAR department. So you can download that and you can start with the consent of the patient and yours from the hospital part. Adaptation of ART services, staff and patient triage. So the questionnaire will be for both for staff and patient, and there will be repeated test for both staff and patients. So for the patients, when we are doing an IVF cycle, we are following 3 tests. One at the starting of the investigations, one at the starting of the stimulation protocol, one at the start, either before egg collection or before frozen transfer. So treatment cycle planning, when you want to do and when you don't want, assess to advise and treatment, and code of conduct for staff and patients both. So this is the sum of evidence I have collected from ASRM and ISRE both, and what they have travel concerns. I have already told all this, that if not necessary, if not very urgent, just postpone for vaccines and for the safety of the patient, whether patient is in containment zone, whether your hospital is in containment zone. You have to consider all of this, and then you can start the treatment. So fresh or frozen embryo transfer, the choice of resumption of practice. So you all know the strategies of embryo transfer are 2: the conventional IVF, that is a single fresh and or more, 1 or more frozen thawed embryos. So now the strategy is freeze all, transfer of frozen and thawed embryos only, and no fresh embryo transfer, because embryo transfer are disengaged from ovarian stimulation in the ovarian. This will also help to reduce the risk of OHSs. And this pandemic time, you don't want your patient to land into OHSs and then get admitted in the hospital. So you don't want that. Resumption of infertility treatment under strict infection control measures. So stepwise fashion, the diagnostic infertility testing, I told you before that, one test, less invasive test like if frozen embryo transfer or IUIs can be done. The invasive or lengthy procedures like ovarian stimulation or oocyte retrieval and embryo transfer, you have to be very careful. Either you need to have 3 or 4 tests before going ahead at each and every step. So strict infection control measures are mandatory during the reopening of the practice. So frozen embryo transfer will be the choice of treatment after resumption of practice. This is the data from all over the place, or from ASRM, from ISRE, and everybody is counting on this. Counseling of the patients about the benefits of cryopreservation. Freeze all is recommended for patients currently undergoing ART, and freeze all to be applied if patients become symptomatic after oocyte retrieval. So whether we should go for fresh ET or FETs, or you know that with controlled ovarian stimulation, there is negative effect on the endometrium, and so there is adversely affecting on the implantation rate on fresh ET. But with FET, there is no adverse effect of ovarian stimulation. So you know all the hormone levels are normal, the endometrium will be prepared well, so FET will be more successful. So frozen embryo transfer cycle, the freeze all policy, avoid OHSS risk. Embryos generated by IVF can be stored and utilized later. So the primary objective of FET is adequate preparation of the endometrium to receive the thawed embryos. So FET has emerged as an alternative to fresh ET in this situation to improve the IVF outcomes. FET not only decreases the risk of OHSS, but also improves the reproductive outcomes of the IVF treatment. So reasons, you all know this, but I'll explain one. Evolution of the cryopreservation techniques, improvement in the stimulation protocols to avoid OHSS, increase in genetic screening to do PGS and all, evidence on better perinatal and obstetric outcomes. So here is a comparison. You can see this is a 2011 study, but very much like in this situation also it will give you an idea why to go for FETs. As a whole, FETs, the clinical pregnancy rate, the implantation rate, and the ongoing pregnancy rate all are high than fresh ETs. So impaired endometrial receptivity in fresh ET cycles after ovarian stimulation apparently accounted for most implantation failure in the fresh group. So FET cycles are also associated. This is proven. This is proven. So there is no argument on this. This is a paper from 2018, and it has told that FET cycles will have less low birth weight babies, less small for gestational age, less preterm deliveries, less placenta previa and placental abruption. So this is our data of our clinic. And you can see year-wise, when we have gone for FETs with blastocyst transfer, we have almost achieved 60% success rate. So in your opinion, in which patient profile the frozen embryo transfer most advantageous? So here is some probable the patients who are at risk of OHSS. You know, the patients with altered endocrine or cardiovascular profile, the patients with inadequate uterine cavity for embryo transfer, patients who are hyper-responders, patients who are undergoing PGS or PGT at the blastocyst stage. So here is another study from 2018, and here you will see that the higher responder group is having the clinical pregnancy rate and the live birth rate, both are high in FET cycles. But in the intermediate responders of the low responders, you can see the fresh ETs are having better success rate. So freeze all with FET cycles have higher pregnancy rates in the fresh transfer in higher responders with 15 or more oocytes retrieved. So if it is for all normal responders, here you can see this is 2015 studies, and here one to 2017 study. So you can see where both the cases, where the implantation rate and the ongoing pregnancy rate is more, even when we have retrieved 4 to 9 oocytes or more than 10 to 15 oocytes. So this clearly gives us a result why we should go for frozen embryo transfers. So how can the compounded stress surrounding the current pandemic affect the assisted fertility? This is really a daunting task for all of us, because we all are feeling the stress. Every day today, we are feeling that we can be infected anytime. We are coming in contact with the positive patients, coming their result after they are visiting us. It is happening every day with me. I'm canceling their cycle, but I have counseled them, I have talked to them, they have given their RT-PCR sample, they went home and the report came that they are positive. That means I was always exposed. So just think for the patients who are already going for stress and anxiety because of they are not conceiving, above that this pandemic, so we have to counsel them a very good way. So stress and anxiety that disturbs the necessary balance of the hormonal conditions required to become pregnant. Automatic hormonal release elevates the heart rate, increases blood pressure, boosts energy, causes physiological and psychological damage, the changes of sleeping and eating patterns, and the chronic mental health problem. Plenty of patients are facing all this. And the patients who are pregnant now because of previous IVF cycles, they are going through the stress mode. So how can we help them? How can we? There are five. These are from ASRM, and this is good for us also. Self-help books with positive self-talk are powerful. Interact with support groups focused on the fertility patients. Collect information from reliable sources like WHO, CDC, ASRM, or our ISAR or ACE. Use relaxation or mindfulness apps. You know everybody is nowadays mobile tech savvy, and so they can go for these apps which will reduce the anxiety and tension and improve their sleep. Limit the social media. We know the social media is full of fake news, so limit the social media and distract yourself from the pandemic related news. So recommendation for reducing the risk of viral transmission during fertility treatment. So as I have already told, if not exactly necessary, if you can counsel your patients, then postponing the infertility care until after the crisis passes, postponing the oocyte retrievals, embryo transfer, and the diagnostic test. So reducing the risk of viral transmission, again, the fertility center should be equipped to treat the couples for if they become positive with the viral diseases. And preconceptional counseling on the risk for sexual and vertical transmission of the infection should be provided. And we should tell the patients about all this, how much we know and how much we don't know. And then only if with their consent, we can go ahead. And samples from viral carriers be processed in a separate lab or a designated space. So cross-contamination samples. So the following measures has been proposed that specimen containers should be able to withstand the freezing temperatures and thawing cycles. Storage of samples in the liquid nitrogen vapor. Use the double bagging or the sealing techniques. We all know this to prevent direct contact of the cryo containers with liquid nitrogen. Sperm washing to decrease the viral load. We all do this before IVF sperm preparation. So what are the chances of vertical transmission? So here, neonates delivered by the positive mothers also came negative. There are evidence of intrauterine infection caused by the vertical transmission in late pregnancy is lacking. So we really don't know the consequences of infection, the early pregnancy, what will happen next, how it will affect the pregnant patient later, how the baby will be affected, really we don't know. If we don't know this, we should explain to our patients everything. Then only if they agree with their consent, with taking all the precautions, we can go ahead. Otherwise, postpone the cycle. Although the evidence of vertical transmission is still unclear, but it may be possible. So here are two cases that in 2020 we have found in a journal published. So the infant was tested 30 hours. The mother was obviously positive. After the birth, the infant was tested 30 hours, came positive. So the horizontal transmission cannot be ruled out. It can be that baby got the infection after birth. And the newborn tested within a few minutes after delivery. And here the tested positive, here maybe there is a vertical transmission. So there are two scenarios also now present. So we are really confused and we don't know how it will affect in a long term. So what are the adopted IVF protocols in current scenario? You all know we have to individualize our patients, normal responders, poor responders, hyper responders, and basis of that we can think of the protocol. The best treatment should be tailor-made with the maximum chances of pregnancy and eliminating the risk of ovarian hyperstimulation. So we know the short protocol is or the gene-rich antagonist protocol, which is good to reduce the OHSS, which is good for the PCOS patients. But the long protocol is obviously the choice because long protocol rather than the antagonist protocol have higher pregnancy rates. So we can go for long protocol, but the duration of the injections will be more. And so we have to explain the patients all this and then choose the protocol with their consent, choose the protocol and go ahead with the treatment. So I have told you all this. So let's go for again the minimal stimulation. Minimum stimulation protocol is a clomiphene citrate or letrozole with HMG protocol. Here you have advantage and disadvantages both. The pregnancy and transplantation rate comparable to the agonist protocol, because there we have more chances that this uses significantly fewer gonadotrophin ampules, so that is a positive factor for the patients. For financial aspect also, so this may be a better option in the patients of poor ovarian reserve due to low risk of uh, poor ovarian response due to low risk of OHSS. The anti-estrogenic effects of CC suppresses the premature LH surge while maintaining a positive influence on the follicular development. But with this minimal protocol, you can have decreased follicular development or less number of follicles, so less number of embryos formed for freezing or freeze all policy. So which is the newer induction protocol? This is the ultra short flare protocol. You all know we give gonadotrophin for 1 or 2 days, and then we go ahead with our stimulation with HMGs. So this is lack of hypoestrogenism, shorter treatment duration, lower gonadotrophin requirement, allows cycle programming, protection from severe OHSS. So this will be useful for your poor responder patients or patients with poor embryo quality, patients with repeated IVF failures. So luteal phase support now in IVF, and we give all various kind of protocols in luteal phase support. And luteal phase support is necessary for all FET cycles because so low progesterone level, delayed endometrial secretory transformation, and shortened luteal phase of less than 10 days. So all these can reduce the implantation, lower the pregnancy rate, increase the miscarriage rates. So what is the standard protocol? There are many protocols, but luteal phase support with progesterone, with HCG and GnRH agonist, I don't go for that because HCG increases the risk of OHSS, and I really have no data with me or no evidence with me with GnRH agonist or my experience. So I go with progesterone, the standard approach for IVF cycle. So all frozen embryo transfer cycle, there is no ovulation. The causes an absence of the endogenous corpus luteum. So no endogenous source of progesterone. So endometrial changes necessary for implantation and early pregnancy are totally depend on exogenous progesterone supplementation. HCG is associated with hyper ovarian stimulation. I have already told you this. And GnRH agonist, I have no experience. So oral dydrogesterone is the right progesterone in my opinion because it is giving very good result and it does not suppress the pituitary gonadal axis at normal therapeutic doses. High selectivity for progesterone receptors and minimizes the adverse effects. Documented evidence of immunomodulation that is conducive for success of pregnancy, and the improved bioavailability of this. In India, where 40,000 IVF cycles are performed every year, the oral route is preferred by the majority of the women because they find this route of administration is more convenient. So plenty of people use cocktail therapy like vaginal progesterone with oral dydrogesterone with GnRH agonist or HCG. I don't use that. Rather than I'll tell you to use injectable progesterone which give me a good result. But there is no significant difference of whatever you are combining or giving as a cocktail therapy. So the key messages to my presentation today. So the infertility is a common occurrence in recent times, and the IVF is the most successful treatment for infertility. We all know this. Our childless couples, they are eager to go through their treatment part. So they are thinking how many days we wait or how many months, because we don't know whether this second wave, after that there will be third wave, people are talking about it. So how many days we'll wait? So FET not only decreases the risk of OHSS, but now it is the recommended uh, process or the recommended protocol to improve the reproductive outcomes of IVF treatment during this pandemic. So FET policy should be individualized in line with the modern patient handling approaches. So the counseling of the patients, each and every step, and their viral detection, they are doing RT-PCR or rapid test with going ahead of the treatment is very necessary. And oral dydrogesterone is effective in infertile women undergoing IVF, irrespective of the cause of infertility or the number of factors of contributing to the infertility. Thank you all. But one more slide on the vaccine IVF. So I have collected this data from ASRM, but even now our government is telling the same thing, and we are telling the patients who are going through the treatment now, even the pregnant patients and the lactating patients, all can go through the vaccine. So whenever your patients are coming, whether they are at the beginning of their treatment, whether they are pregnant, whether they are lactating, you can advise them that they can go ahead and take the vaccine whenever it is available to them. Thank you all. Thank you for listening. Thank you for attending this session.
So the first question is like, what are the set of precautions that we need to follow during IVF cycle in terms of pandemic?
We have to tell them to isolate themselves as much as possible from the others, because maybe they will stay at home because but the family members will go out and come back, so they really have to maintain the social distancing even at home. So you have to counsel the patients about that, and then repeated testing before going for investigations. I told either the rapid test or the RT-PCR, at least one RT-PCR in one IVF cycle is a must. So either you can do that before starting the stimulation for the patient or before the transfer. So I usually do it both the times, rapid and RT-PCR. I do 4 times. So 2 times I do rapid test. One is before doing the hysteroscopies or the investigations. And then before starting the cycle with gonadotropin stimulation, I do an RT-PCR test. And then before the ovum pickup, I do an RT-PCR, or before doing a frozen embryo transfer, I do an RT-PCR test. So by that, you can take the precaution for the patients. You know that the patient is not symptomatic and the patient is not having any infection. But for the medical staff and from our point of view, wearing the mask, because I'm sitting all alone here in this room, that's why I'm not wearing the mask now. But otherwise in the hospital, because it was not audible with the mask on that clearly, that Atish told me during our trial session. So I have removed the mask, but all the time sitting in the hospital, whether you are having a patient or not in your room, because this room is closed and there is either AC on or exhaust on or whatever. So you have to wear the mask all the time. So I am wearing the mask all the time. Wear the shield whenever your patient is coming. Change your clothing every day. Each and every day, change your clothing. When you go home, take a warm bath as soon as you reach home, because at home you have kids, you have small children. I tell this for all my staffs. So all my staffs are following this every day, and we do our staff repeated rapid test every 10 days, every 10 days, without any symptom also. And if any of the staff is a little bit of symptomatic, then we send them for RT-PCR. And if it is positive, we just isolate them. But as our all staffs have completed their second dose of vaccines and our vaccination, we are almost 2 months post vaccination of second dose. So, but we don't take any risk. We follow all these protocols.
Next question is like, should I cancel or should I stop during this pandemic?
No, if you can follow all the protocols, I'm not telling, if there is no urgency, if you can tell the patient that patient can wait for a few months. See, you have to select your patient very carefully. The patient who is at the age of 40, maybe you can't tell her to postpone or to delay, because every month is important for her. The patient who is at 25 years of age, maybe not much urgency, you can postpone for 2 to 3 months and see how the pandemic goes and then take their treatment. So you have to categorize your patients accordingly their need, and tell them how we are going ahead, because getting pregnancy, becoming pregnant is okay, but you don't know the transmission, the vertical transmission risk, or any risk factor. If in the early phases they get infected during their pregnancy, what will happen for the baby? We don't have all those answers. You have to counsel your patients, tell everything to your patients about all this, and then go ahead with the treatment plan.
The next question is that you had told us in detail about the usage as well as the various protocols. We are keen to know the usage of enoxaparin in IVF, specifically in this times of pandemic.
Yeah, it's good. I luteal phase support. I didn't mention about all those drugs which all we give. I just mentioned about progesterone because that is the standard method. And but I'm using enoxaparin for almost all my patients now, because it will give you a better chance of implantation.
So the questions are done, and I'd like to take this opportunity for thanking you for taking time out of your busy schedule,
Thank you.
and for such a great presentation which has been power packed with the references and the guidelines from various uh, elaborated guidelines from various organizations like ASRM, ISHRE. So it has given us a great insight in terms of unlocking our IVF in this pandemic time. And I hope that our audience has been greatly knowledge and greatly benefited with the presentation that you had provided to us. Thanks a lot, Dr. Aritra. Thank you very much for your time and for your presentation.
Thank you. Thank you very
Second,
much. Thank you all. Stay safe and stay healthy.